We have a way of changing their brain.
That confidence, to me, is the first thing that I want to see, because if the confidence is there, the safety is there, and then we can try shifting.
What's going on inside you? And she said, I feel as if I should be in pain, but I'm not.
That feeling of ease, confidence, strength, that all seems to build together. That's the synchronicity, the cooperation, there's another word I'm looking for, unity.
What they don't realize is the patient uses catastrophizing language because nobody believes them.
And it's very profound to watch something come online that has been turned off for a very long time.
It is not possible to get MCAS if your vagus nerve is working, and in Ehlers-Danlos patients, it never works.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about, or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim Pittis.
I am listening to your podcast with Dr. Massey Reynolds. It's so fun.
Thanks. I think it's had over 3,000 views already, which is fantastic.
It's huge.
And there was somebody that had commented on Instagram about the success that they had with FSM. And it's so nice to see a fan who's a clinician that we don't know doing great things. And it was like a tear that was confirmed with MRI before and after. So I want to reach out to this person and be like, who are you? Let's talk about what you're doing. And how did you do that? The podcast is called The Process with Dr. Massey Reynolds. For anybody that's listening, he's the orthopedic surgeon that we brought to Arizona. And we just have a really great 2-hour kind of chat about FSM and a lot of other things too.
Oh, and the compatibility of attitude and his intuitive, spiritual,
philosophy,
passionate self that he brings to medicine is completely compatible with our ethos. And it's a perfect fit. The only thing I kept waiting for you to say when you started talking about feeling safe is 40 and 89.
I know.
You put them in hero pose and we run frequencies. No, we run specific frequency to quiet the panic in the midbrain.
Right. But maybe that will be the teaser for people, and they'll be like, what are those frequencies? I have to attend a course and reach out to us.
I can hold the happy thought. That would be the course, but it was like, no, really, it's not just hero pose. It's the fact that pose combined with, I never have anybody do hero pose, but I run that's not out of 40 and 89.
Right.
To get, they just calm down.
Correct.
And when you treat concussion in vagus, their voice drops.
Right. You had mentioned that we were treating somebody years ago, and that was part of the practicum. And you had mentioned that you were doing range of motion with the cervical spine and the shoulder. And all those objective markers were checked to have improved. And then as I am staring at them, going, something else is different. And when you do those puzzles where there's like a split screen of 2 images and you have to find like the 10 differences, I'm like, what else am I missing that's different? And then you'd said it and your voice is different. I'm like, her voice is different. That is it. And then there was just that calmness in their nervous system that you really hear or experience when their voice changed, and not even just the pitch but the speed.
Yes, their blink rate slows down, the whole posture relaxes, and it's not just the pain relief, it's not just that they don't hurt as much, is that we have a way of changing their brain. And it's when you recognize, at least for me, once I started treating the central nervous system as it relates to the peripheral system, and the central nervous system in neurodegenerative diseases like Parkinson's or strokes, and found that we could stimulate and change the basal ganglia and the thalamus and the hippocampus and the vagus. So once the vagus, then it was game over. There was no denying it. And it really brings home the power of FSM and the connection. Your sports course, what did you call it? The reboot?
Yeah.
No, wipe and load.
Wipe and load, reboot's the same. We use both.
That's wipe and load. It's like, I've been doing it, but I never systematized it. And now it starts in the very first part of the myofascial section. We start with myofascial pain because you have to be able to feel the frequencies to believe. Your hands are going to convince your brain that the frequencies actually work.
Right.
But then you can't quantify what you do to the brain when you treat the midbrain, and the expression on their face changes.
Correct. We were doing gait assessment last week with the patient who was coming in for some pretty complicated knee pathology. My nickname at the clinic is Hail Mary because I'm the I'm the stop before Dr. Reynolds does what he needs to do. And we're having a conversation about at my hip, looking at my knee. And I said, I am looking at those things, yes, but I'm also looking at your face. So when they were saying, you're looking at my face, and I said, I'm looking at your face. I'm looking at how your face is, how confidently you're walking. If you're at peace with yourself walking. And they were like, oh, yeah, it feels different to walk, but I couldn't explain it. And I said, yeah, maybe you're searching for the pain and it's not there. Or maybe you're searching for like apprehension and it's not there. And you can see so much with like heel strike and toe off. And that confidence to me is the first thing that I want to see, because if the confidence is there, the safety is there, and then we can try shifting.
The first 40 and 10 patients, like the first 10 of them that I treated, I was all happy that they were out of pain. And they were like, until we got to about number 7. And she had that same funny look on her face that the other ones did. And I asked her, what's going on? What's going on inside you? And she said, I feel as if I should be in pain, but I'm not. And that's the first time I ever ran 40 and 89, because that's where the pain center is. In fibromyalgia, they show that part of the brain actually expands.
Right.
And look on the face when they first stand up, when you're looking on the, when they first stand up, when you've been working on the pelvis and the psoas and their hamstrings and knees or ankle, and their whole, it goes all the way up because you've changed the whole base.
Right.
And their foot, their ankle actually bends, and they're, in the chiropractic world, you can make the carpals and the tarsals work.
Right.
And so the foot actually rolls.
Right.
And the look on their faces, huh? And then you do 40 and 89. We did 40 and 89 when somebody was swallowing ice chips.
Yeah.
Because he had scarring in his esophagus.
Right.
You do 40 and 89, take down the fear. So first they feel safe. Then you increase secretions in the cerebellum, because the cerebellum has this little file cabinet.
Yep.
Let's stand on 2 feet with balance. Oh yeah, there's the card. Okay, I got that. So I know what muscles to fire now that, oh wow, they all work. So I can use the original recipe. I don't have to use all the alternates. Got it. Then the sensory cortex tells them, walk down the hall. As a substitute for a gait belt, I just grab the back of their pants, their trousers. why are you grabbing? Because your balance is, and then they wobble all over because they don't know where the arms face. We walk down the hall, toe heel, we walk back, toe heel, but about the second time I let go of their pants and they can balance, but their arms don't move.
Right.
And they're walking toe heel, and pretty soon, and they're looking at their feet, and it's look up. Oh, okay. Then they start to get input from their feet to their brain, and they're walking toe heel. Why am I walking toe heel? Because your spinal cord thinks that you always walk heel toe, so it doesn't have to pay any attention to what you're doing.
Right.
So we rock toe heel. So you get all the same muscles up the spinal cord to the brain, just in a different order, so it pays attention.
Right.
And after about 25 feet, they start, you can see it shift.
Yeah.
They start trusting their feet, they start trusting their balance, and then they can go to heel toe when they start moving their arms.
Sometimes we do, and there's so many different variations and progressions you can do. And that's my favorite part is, do we start just in hero pose? And then do we close your eyes? And then do we go to a balanced foam pad that is slightly unstable? All just in standing, because sometimes walking can be too much for something that is, especially for an athlete who has more sensory perception, because they've done millions of these patterns. So to get them to do a squat, for the average person, a squat pattern might be pretty challenging, but for an athlete that's trained this millions of times, we have to do a squat with eyes closed on a foam pad to get that same level of challenge. Yeah, that's just the fun part. And when you can see the disbelief, the uncertainty turn into, I got this, and then you see the muscles come back online, it's...
The look on their face is just someplace short of ecstasy. It's like
totally
joy.
Right. And then that's when I almost want to pause and say, you see how that feels right now? This is what we want. That feeling of ease, confidence, strength, that all seems to build together. That's the synchronicity, the cooperation, there's another word I'm looking for, unity. You know what I'm saying? When
the flow.
The flow. Yeah.
Biomechanical flow. And I do it with the wipe and load on the table, have them stand with a wrap around their neck, towel under their feet. And if it's a walking or a vertical posture thing, you run 40 and 89 while they're standing, and having them just shift their weight. Shift your weight on your pelvis and your leg to your right leg, shift your weight to the left, and then move one foot forward and then back, because that's the movement. And you do this while you're running 40 and 89. And then you make the same movements while you're running increased secretions in the cerebellum. Run the same movement while you're running increased secretions in the sensory motor cortex. Wrap around their neck, towel under their feet, and they've used all the muscles while we're using the feeling safe.
Right.
You improve coordination, send the information from the sensory cortex to the spinal cord, feel safe again, and now we're going for a walk.
Right.
And it's like a mix and match thing. It's so much fun.
I know. And I'll get that from time to time in the clinic, where patients will be like, you're having a lot of fun watching me do this right now. I'm like, yeah, because I get to see things in real time that you're feeling and I'm witnessing. And it's very profound to watch something come online that has been turned off for a very long time. I have a couple things before we go too far. There are some patients that don't like the feeling of 40 and 89.
Interesting.
Yeah. And I know we have that one case of the 40 and 89 made a pain increase, but that was run for a very long time.
Oh, wait, let's be specific about a very long time. through 6 is 18 hours in 3 days. 6 hours a day for 3 days.
Right.
That's not normal. You don't run anything that long.
Right.
Just no, not one frequency, and certainly not for that one brain part. But for her, she had such a traumatic past. 40 and 89 for the first 2 days felt great.
Yeah.
And it wasn't until actually the end of the third day, the 18th hour, that the wheels came off.
Right.
That's okay. That, to me, it was good news, bad news. It's 40 and occult infection. What 18 hours of 40 and 89 did, and what 2 minutes of increased secretions in the midbrain did, was teach me how much power we have. The fact that we can turn it on in 2 minutes, and it takes 18 hours to turn it off. The fact that we can turn it off. And as Dr. Woods said when he did the case report, this is what happens when the thalamus and the hypothalamus are off. This is the role they play that they need to play for normal function. And this is what happens when you can turn it off. And what I didn't get to ask him that first year, which I got to ask him this year, was how do we turn it off? How does that even happen? And he had to say, like everybody else, I don't know how you did it, but you definitely did it.
Right.
Proof now that you did it.
Right.
And then 81 and 89 turned it back on.
Right.
So patients for whom 40 and 89, they don't like it.
Yeah.
As a psychologist, everybody has trauma.
Right.
And most of the people we see have pain.
Right.
Most of the people we see were the Hail Mary. They've been in pain for quite a while. 40 and 89, if you think about it, is reducing the degree to which you are accustomed to the pain.
Right.
Amplification.
Right.
The midbrain changes from a pain suppression to an amplification. That's a possibility. They just get used to it. The other possibility for people, especially in your patient clientele, athletes are really good. The people I don't run 40 and 89 on are the people where the midbrain is being used, the thalamus is being used to suppress pain. You run 40 and 89, and it's even in the slides, one of the 983 slides in the core. You run 40 and 89 when the patient is using that part of the brain to suppress pain. It suppresses the ability of the brain to suppress pain.
Right.
It's a good indicator. I can tell, you can probably tell when an athlete is using his brain to suppress pain.
Right.
Yep. You know you're treating an athlete or a patient with really good pain suppression psychology, and they tell you their pain is a 5. You look at your x-rays, at their x-rays, and you go, ooh. And you look at their physical exam and go, ooh. And then they tell you their pain is a 5. You don't look at the patient and say, that's a lie. You say, okay, their 5 is a 7. And that's, on that patient, you don't run 40 and 89.
Right.
Their midbrain is doing its job. It's producing morphine.
Right.
It's blocking the pain messages. Yeah, you don't need to know about that. The sensory cortex doesn't need to know. I don't need to. You don't need to know that. It's
Right.
a 5.
Yeah.
Okay.
I think this is an important thing to talk about because We talk a lot about when the needle goes the other way, when patient's pain is very high and it doesn't match the clinical exam. Again, in the podcast, Dr. Massey and I are talking about, he's talking about some people that are in excruciating pain, talking to him about knee replacements. And he's like, you've only had this for 3 months and you have a lot of cartilage left, and let's try some other things, versus an octogenarian that has bone on bone and is running a marathon just fine. We talk a lot about the pain patients that say that they're a 9 out of 10. And you do a great job of, those of you who are listening to the podcast, you missed a pretty epic eye roll just now from Dr. Carol. And we know when they say it's a 9 out of 10 and they drove themselves to the clinic and they have a full-time job and they're doing all these things that a 9 out of 10 pain patient wouldn't be able to do. You do a great job of boiling it down one step and saying, is the 9 out of 10 pain, or is it how much you mind it, or how much you're irritated by it or annoyed by it? Or
there's a difference between actually hurts and how much you mind it. Okay, so you minded a 9, but how much does it actually hurt? So once you tell them what the difference is, oh yeah, okay, I guess it's about a 6, 5, 6, but I really hate it. It really hurts. And that actually tells you something about what to look for.
I was just going to say, we had somebody a couple weeks ago who it wasn't how much they were irritated by it or annoyed by it or mad by it, but it was how much they were worried about it, because they had seen so many other teammates have similar pain that ended in a pretty catastrophic result. And so a lot of the conversation was, until we know, you can't go there, because pain is different for everybody. Objective findings are different for everybody. Even MRI, where you have quantifiable data, is different for everybody. What is surgical for one meniscus could be conservative for another. Healing rate is different. So I think we have to remember the patient education that comes with the amplified emotion that is attached to the injury.
I had a patient last night. We were doing a video consult for 3 hours. And at one point during the history, so this is a hypermobile patient, was a ballerina, training since she was 8. So she's been training, she was 18. And so 10 years on toe when she was 10.
Wow.
And I went, that's wrong. And she said they were Russian. Okay. That's
Because
why
they normally wait to go on the points for
on point until you're 14. You just don't even go on point until you're 14 or 15. And that's even that is tough. But the Russians start people on point start women on point when she was started on point at age 10. And I said, that is why there are no 35-year-old Russian ballerinas. They're done and in pain for the rest of their life when they're 25, 28.
Yeah.
And she went, yeah, she knew that. But anyway, she was hit by a taxi cab. She's hypermobile, has 9 out of 9 Baton points. And she had all this imaging done. And she and her mom both used this catastrophizing language. It was horrible. It was excruciating. It was devastating. I said, wait, okay, that's how you feel about it. Can we just deal with the facts? Because when you use language like that, you don't have to, I'm looking at your imaging. I'm looking at the physics of the accident. I believe you. So you don't have to use the big words to convince me that you're in pain.
Right.
It was devastating. No, it hurt a lot. And there's reasons that it hurt, but you don't have to convince me.
Interesting.
And it's bad for your brain for you to use words like that.
Yeah.
And they went, what? It's bad for your brain. It's scary.
Yeah.
Don't scare yourself.
Yeah.
When I did this, that increased my pain a lot.
Right.
I believe that. This was devastating. You're still talking to me. I know you have to be horizontal most of the time, but you're still talking to me. You can eat, you can see, you can swallow, you can poop, you can pee, you can go for a walk, you can get a latte, nothing you have scares me. You
Right.
can do all those things a lot of people I see can't do.
Right.
So it increased your pain a lot. Let's move on from there. Then what happened? I believe you. Oh, okay. And then this is a management problem, because so somebody would do something that made her feel better, then she'd go out and do 3 things in one day that would each one of which would be too much. Let's create a reasonable expectation and a progression. It's going to be 6 months. And for the next 3 months, you don't get to lift anything heavier than a latte.
Right.
What about a purse and a thing in a bag? Well, you can put it in a backpack, you can put it in a fanny pack, you can put it in a chest pack, but you don't get to carry it on one shoulder.
Right.
Oh, nobody ever told them that.
Right.
So that's the difference between FSM and other practitioners, because we think about what it takes to not make it worse.
I think about Roger Billica so often when it comes to those lessons he told us about watching your language and your verbiage, the things that you say. It's in those very first slides of the core. I think it's the concussion protocol where the slide says, if you've ever applied a Band-Aid to a screaming 3-year-old, you understand this concept, right? And it is just taking down the energy a little bit, for lack of a better term, so that you can see things objectively. The part that I didn't always think about was what you just said. I believe you. You don't have to convince me. I didn't realize that would be a thing for some people.
It is. For pain patients, it is, especially the ones that use catastrophic language. And when I became an IME, that's a strike against you.
Oh,
They use catastrophizing as, this is a bad thing that this patient does. And what they don't realize is the patient uses catastrophizing language because nobody believes them.
right.
I had one patient, a poor thing, people had ignored her neck pain and she needed a spinal discectomy infusion, and they had ignored it for a year, 2, 3, 4 years. And she had this terrible arm pain and terrible referred pain between her shoulder blades and bad reflexes and all this other stuff. And her language got more and more catastrophizing because nobody believed her. So her pain wasn't just a 7, it was horrible. It was excruciating. It was devastating. And it's a 7, and you've earned it. And you have to understand that in medicine, in this culture, especially in the post-opiate epidemic, nobody cares about your pain. Excuse me? Nobody cares about your pain. That's not their problem. They can't give you opiates. They can't give you anything but super Advil that's going to mess up your kidneys or your blood vessels or your heart or your stomach. Right. So they're going to do that, and they can't even give you tramadol for more than 10 days. So they do what they can. They send you to PT and hope you get one that isn't going to make you worse. But you go to them for pain relief, and unless they can fix it with an injection that they can charge $2,500 for, they don't care. They can't. They're not allowed. They're not allowed to care. It's creepy. With FSM, for us, it's information.
Yeah. It's all information. And when you have patients that I feel will say, sorry if that's too much information, I'm like, there is no such thing as too much information. Because
Well
they do,
said.
they start, yeah, because I can always use it. Even if I'm programming a custom care for someone's acute injury, and then they start talking about digestive problems. Oh, you probably don't need to know that. I'm like, oh, you'd be surprised. Give me.
We're
And
together.
people, I don't think, are used to, I think we're living in a lot of healthcare where it's very myopic and you have to stick to the one reason why you came in. And I even have that with my primary care. She's fantastic, but there's only so many things that you can talk about. And then she's like, oh, we're going to have to book a separate appointment to talk about this. I'm like, but doesn't this correlate to that? And she's like, it does, but we can only talk about two things. Like, so I
Yeah.
think people, and she's a fantastic physician. So I think people are used to just trying to stick with what they think is relevant, and they don't understand we need all of the information for it to be effective.
Yeah. And transitioning that into traditional medical practice is challenging for our
Right,
practitioners.
right.
They still have to have 1, 2, 3 ICD-10 codes, and they have to get done in 30 minutes or 60. And
Yeah,
it's easier. That's the first question I ask. What's your practice model? How many of you have 10 minutes? Oh, good, nobody. How many
right,
of you have 30? Half the class. How many of you have 60? The other half of the class. Oh, goody.
right,
Okay. We know from Guillaume Soraya that you can get a lot done in 30 minutes, 2 or 3 times a week,
right.
with exercises done properly.
Yeah.
And it's just, you can get it done.
I think sometimes the longer protocols can scare patients. So a lot of times when I'm programming a custom care, we have that very real conversation of how long do you want to sit with this device on you? And they're like, whatever it takes. I'm like, no, that's not true. Tell me what is realistic for you.
Yeah.
They're like, okay, 30 minutes. I'm like, okay, I'll make you a program for 30 minutes. 30 minutes is better than no minutes. And so I would rather make a shorter program that somebody can run maybe multiple times a day if they feel like it, than something that looks overwhelming that's never going to get taken out of their gym bag.
Yeah. And you can have 30 minutes on knee pain that focuses on the meniscus. You have 30 minutes knee 1, knee 2, 3,
Yep.
and meniscus, cartilage,
Fat pad.
ligaments, fat pad, tendon, flat tendons, round tendons,
Right.
knee 1, knee 2, knee 3.
Right.
And you run them, all 3 of them in a day.
Right.
What's happened with me lately, I just got lucky to have people that could afford it and that had common sense. I have nighttime programs.
Right.
This patient I have that has Ehlers-Danlos and all this neck stuff, she has a 4.5 hour nighttime program
With the magnetic converter.
with a converter.
Yeah.
And I've had patients in the last 2, 3 weeks, especially, that you have all of the things separately, and then nighttime you choose what they need the most. The Ehlers-Danlos patient has a nighttime program that runs neck pain, cervical instability, facet-generated pain, and she's got pucks at her neck and her feet, and well, at both sides of her neck for just the neck, nighttime neck. She's also going to have a nighttime hypermobility.
Right.
And they all run concussion in Vegas first. And then you run torn and broken in the connective tissue, and you run 40 and 10, and you do the whole hypermobility thing at night.
Right.
And I just got lucky. She could afford it. Emily could. And it's being able to do it with the converter in bed at night. It's the only time I'll treat myself.
I know during the day, most people are too busy, but yeah, the options of running things at night, shorter protocols that are run more often. when people ask what's better, a longer or a shorter one, and it's the one that they're going to run, the one that works for their, and people hate that
Yeah.
answer, but we are asking patients to, especially in the early stages of treatment, to believe that the treatment is working. And I get a lot of healthy skeptics, which I don't mind. And until it works,
Bob.
what's our new phrase? Hard to believe until it's impossible to ignore.
I love that phrase. Hard to believe until it's possible to ignore.
Yeah. So
we have to give that to Kevin, and it has to go on the website. And if Marilyn's listening, she needs to put it up on Instagram. It's hard to believe until it's impossible to ignore.
yes.
It's
I entered the world of FSM as a skeptic with a bigger eye roll than what you just did.
yeah.
So I understand it. I think we should enter with healthy skepticism. That's what a good scientist does. So I think it's okay. So question really quickly, do the magnetic converters work as well as towels for Ehlers-Danlos programs?
We're going to find out.
We're going to find out. Yeah.
No reason it shouldn't. I hope it does, because you have an Ehlers-Danlos patient that has a full-time job. If they don't have a magnetic converter, you've got problems. Go to school, they do all these things. It's what really is, it comes down to what they can afford.
Right.
And
can we, just while we're on the Ehlers-Danlos, I have a challenging patient, one of my favorite patients, but challenging, and it's an Ehlers-Danlos MCAS, a highly sensitive EMF patient.
okay.
And I do believe we have totally improved quality of life. However, there still are some symptoms, especially with digestion, highly sensitive to foods, is on extremely limited diet, and gets a lot of upper gas, belching. It will increase during a treatment. We can turn it down during a treatment. But the combination of MCAS and Ehlers-Danlos is pretty common, isn't it? Like,
You don't, it is not possible to get MCAS if your vagus nerve is working, and in Ehlers-Danlos patients, it never works. So, duh.
so the course of action has been obviously concussion and vagus, but also just doing the vagal tone protocol on its own, I believe, is helpful.
On the other thing with concussion and vagus, I increase the amount of time. So the standard is 2 minutes for trauma, 4 minutes for increasing secretions, 2 minutes for vitality on the vagus.
Yeah.
2 and 4 and 2 and 4 for trauma and quiet the activity of the medulla and the midbrain. So that's the standard. I run 40 and 89 for any place between 4 and 30 minutes. So I have one custom care in the office with written on the back and felt pen plus 89 means 89 runs longer on the concussion and vagus.
Right.
And when 89 needs to run longer, so does increased secretions in the vagus. So I'll run increased secretions in the vagus for 30 minutes.
Right.
And but they have to do other things, especially with belching and stuff.
Yeah.
You have to have stomach acid. You have to use, oh, but I have to take Prilosec. Okay. No, but it takes a long time to get off of Prilosec. But that's how you empty your stomach.
Right.
You're belching because your stomach is starting to digest your food and it makes gas, and that's how come you belch. And then but you don't have enough acid to empty your stomach. The food has to go out.
Right.
And that takes acid. And once they made omeprazole and all of the acid blockers, and then all of those over the counter. So once the patent went off of them, they decreased the dose by half and made it over the counter. None of them, everybody listening, are we there? Everybody's there. None of them have been studied for more than 2 weeks.
Oh, wow.
None of them, no studies for more than 2 weeks Now, this was back in the day when I was working in the GI world. So let's pretend that maybe there was something, somebody someplace did a 4-week study, but in general, they're not studied for that long. And there are people that are on them for 14 or 17 years.
Wow.
And the potential side effects with the long-term use include stomach cancer, osteoporosis. There's another couple of catastrophic diseases that are just a result of using acid blockers. You have to add acid to digest your food, to import, to make minerals absorbable, to make B12 absorbable. That has to be done. The way you make stomach acid is to get the vagus to work. The other thing that I do is you investigate digestive enzymes, and I use Designs for Health because it has ox bile to help digest fats, but it also has a teensy bit of betaine hydrochloride acid, stomach acid, just a little bit.
Right.
Just a little bit. And then the stomach empties.
Right.
So it's gastroparesis patients do really well with vagal tone and digestive enzymes.
Right.
But I have to take Prilosec. Okay, here's David Mesnick's slide on how to get off of acid blockers. It takes 1 to 2 months, and you're going to take digestive enzymes with meals for 1 to 2 months while you're getting off of it. And then, yep.
Right. There it is.
Yeah.
We have a couple questions before our time is almost, 10 minutes left. Okay. Any thoughts on liver failure, male 44-year-old?
Sure. Where was it?
I just closed it. Sorry.
Oh, okay. Liver failure from what? Virus,
Leaf,
alcohol.
you'll have to give us more details. We'll let Leaf type in more details and we'll move on. Kate says, I use Concussion in Vegas on a TBI client and he's able to relax and is a puddle at the end, which is good, but also more difficult to get him off the table. Should I run 49-103 at the end?
Usually getting them off the table, 6.8 and 38 is
Constitutional factors. Yeah, brings everybody back in their body. They feel super safe and grounded. If that doesn't work, I'll try 35 and 102, which is balancing the energy centers, can sometimes help.
Yep.
And sometimes for my athletes that are immune to both of those, vitality in the forebrain, 49 and 90 can help. Say hello, come back to me now. Time is up.
Yes. Yes. I don't know which part of the brain gets stoned.
I think all of it does.
And
I think their fascia just gets stoned. But Louise asks, can EKG electrode sticky pads connected with alligator clips be as effective as wet towels?
Yes, they're just EKG pads. You just have to turn the current down and they get prickly. The stickiness, actually EKG pads don't get prickly. They're small. You might have to turn the current down because the current density is a lot, because they're 1 inch by 1 inch or a 1/2 inch, 3/4 of an inch by 3/4 of an inch by 3/4 of an inch.
Gotcha.
And that's, you can get extra resistance with that, and that could give you prickling. EKG pads on babies, if you're treating babies, EKG pads on the face post-operatively. That's pretty cool. Up above the bandage, down below. You can use, they should, you have to, number one, you're going to have to see if the alligator clips work, because the connectors are different.
Right.
If you can get EKG pads that have a pigtail like the FSM units, then you're better off. So try it.
Yeah.
Anything that'll conduct current and frequencies will work.
Denise, have I tried 84 since it's diaphragm also? I have, because sometimes when I'm treating someone's vagus, I'll treat the diaphragm because everything is, especially if I'm treating trauma or scarring in the vagus. Going after it through the neck and going after it through the diaphragm can be effective. I have tried that. I think it's less to do with that and more to do with kind of what, Carol, what you were saying with the stomach acid. We have to also remember, and it's hard for us who are FSM super fans, is that it's an adjunct, so it doesn't fix everything by itself. So sometimes we need to bring in digestive enzymes or something else, but you might go back and try it again.
The other thing with, whoops, stop
Sorry.
erasing questions.
Sorry, it's just
I know. I said, you want to get it off your list of things to do.
I do. It's the best I can do since I have this proverbial list that doesn't go anywhere. At least I can do is check the questions off. Oh, going back to, I just opened up the answers, and Leaf had written back when you'd asked about the liver failure. He said, unknown, but liver enzymes are high and pulse is also quite high at 152 with minimal exertion.
Whoa.
All the HEPs have been negative.
So it's not hepatitis. So it's not viral. What medications is he on? How much does he drink? A pulse of 150, that's a cardiac thing until proven otherwise. I would just start with the basics and a lot of 40 in the liver. That's all I can think of. Unless you treat the liver for toxicity, fibrosis, necrosis, because the liver enzymes are high in the blood because the liver cells are breaking apart, and the enzymes that are in the liver cells are out in the bloodstream where they don't belong. I'm stuck on a heart rate of 155. Excuse me? No, is it, are they in sinus rhythm? If somebody has a pulse of 155, you get in your car and you take them, you tell your patient you're going to be late, you take them to the emergency room, you drop them off, you tell them to call you when they're done, and you send somebody to pick them up, or tell them to take an Uber back to pick up their car.
Right.
155 is go to the emergency room now, because they can tell whether or not they're in sinus rhythm.
He said no alcohol. Yeah.
And the only other is medications. What does he do for a living? What's his pesticide exposure? What's his chemical exposure? The liver doesn't fail for no reason. Is he a vegan? He can't methylate B12 or folate. Can't phosphorylate B6. He hates broccoli. He hates cauliflower. Doesn't ever eat vegetables. Oh, ick. He went wild mushroom picking, and they tasted great. What if one of the mushrooms was amanita mushrooms? He's going to be dead in 3 days. That could be a thing. History is important there. The liver doesn't fail for no reason. Liver enzymes don't fail for no reason. The heart rate of 155 would scare the bejesus out of me. Thank you. That's the first thing I take is the pulse. It's just they'll put a little pulse oximeter.
Right.
And what's interesting is sometimes the pulse oximeter will tell you their pulse is 43. But then my GP mentioned, because George's pulse was 33. So I got a pulse oximeter that runs a strip, and the pulse looked like a fence post. It's just like a fence, no spikes.
Right.
And then the GP looked at it and said, yeah, it only picks up every third pulse. So his real pulse is about 170. You need to go to the ER. Okay. He's an atrial fib.
Leaf wrote, in emergency now, sinus rhythm okay, no meds, not vegan, no mushrooms. So.
Okay.
Yeah. And then Denise had, he said one more thing, had some AFib in the past, but ECG clear now.
What are you reading?
I'm on the answered Q&A.
Oh.
The answered tab.
Okay.
And then going back to the open tab, Denise said she did want to say 40 and 84 when she had someone who was belching and it worked, running 40 and 84.
That's interesting.
I will try that, Denise.
Diaphragm. That's the other thing is I don't believe 84 is the diaphragm since it's worked so perfectly for the cerebellum. And the velum and the diaphragm are completely different, have completely different functions. So I
Yeah.
don't believe that 84 is the frequency for the diaphragm. I just don't.
Okay.
It's not investigational, but just because it's on the list doesn't mean I have to believe it.
Right.
I hate to be difficult, but
So if you were to treat the diaphragm, what would you use?
it is a very particular muscle.
Yeah.
And it's innervated by C3, 4, and 5.
Yep. Keeps the diaphragm alive. Yep.
And it's who can't remember that mnemonic. I wish I had said that.
So I treat it also as a muscle. I will go to 77, 62, 46 first.
Yes.
Before hitting 84. And more often than not, one of those three, something happens.
Yeah. 77 and 46. You're the one that I credit you with making me try 46, and it works. And
for contractile tissue, it is very sarcolemma specific, I believe.
Yeah.
That's my 4 o'clock alarm going off. How rude.
Rude.
I'm not done yet. I don't want to go.
No, I feel like your basic 7-year-old.
Yeah.
Or maybe 5-year-old. Yeah. We have some sort of time warp here.
We do.
Good.
It's a good time warp.
It is. And I think I'm here next week, aren't I? Am I? Are you here next week? I
am.
Oh, I think I am. Let's see. June 3rd. I am. Yay. I'm excited.
Great.
Yay.
Wonderful. I'll bring my list and my coffee, and we'll get to some of the things, and we won't get to others, but
how it goes.
That's just how it goes. Thanks everybody for coming, and we'll see everybody same time, same place next week.
See you next week.
Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.